will be.
مسجلين كتير، احنا عندنا الكباسيتي 1000 بس، بعدين هنعمل لايف ستريمنج على اليوتيوب للأعلى أكثر من 1000 بعد إن شاء الله.
ما شاء الله.
طيب نبتدي؟
يلا نبدأ.
نبدأ إن شاء الله. بسم الله.
بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today we are excited to listen to one or three speakers who is outstanding and expert in one of the devastating inborn error of metabolism, which is an X-linked disorders characterized by multi-system involvement, including burning sensation, paresthesia, and stroke and cardiomyopathy. And we will take you through the journey of clinical features and management and monitoring, and also case scenario and experiences, and also navigating the complex monitoring and real life management in patients with this disorder. This disorder is called Fabry disease. And our outstanding expert today is Dr. Rawda Sumbul and Dr. Khalid Naji and Dr. Mamdouh Al-Katawi. So we will start with Dr. Rawda. Dr. Rawda Sumbul currently working as medical genetic consultant in Al-Khatir Central Hospital and head of a newborn screening program. She has Arab and Saudi board in pediatric. Then she finished her fellowship at King Faisal Specialist Hospital, and then continue another fellowship in medical genetic and inborn error of metabolism in McGill University. She has also master's degree in healthcare management and leadership, and she is a head of medical genetic unit since 2010 until now. And she established one of the biggest enzyme replacement therapy units in Saudi Arabia. And also she is awarded for several awarded by Ministry of Health because of her achievement and performance. She has plenty of publication, also teach many students, resident, and fellow. So we cannot wait to listen to Dr. Rawda about advanced care management and monitoring. So welcome with me, Dr. Rawda Sumbul. Dr. Rawda, the floor for you.
Yeah, thank you very much, Dr. Majid, for this and for introducing me, and thank you for all the organizers and for all my colleagues that are going to share this very important educational topic. And I hope we will reach our target and our goal of this educational by early detection of this disease. So today Okay, just would like to share just my slide now, and then so today our talk is gonna be focused on the Fabry disease, where we're gonna just define what's the Fabry disease, going through the clinical feature, quickly over the clinical feature and the diagnosis, and focusing more on monitoring and management of this disease. This is my disclosure. This is the my disclosure, and then So Fabry disease is considered a progressive, life-threatening disease, and Fabry it's one of the most common lysosomal storage disease. It has an estimated prevalence of 140,000 in males and 1 in 20,000 in female. And the mutation of mutation, it occurs in the gene, the GLA gene which is present on the oxychromosome, and the effect in this gene causing a deficiency of alpha-galactosidase enzyme, and causing a pathological accumulation of a substance called the globotriaoscyl ceramide. And in this gene, there was more than 1,000 mutation that has been described worldwide, and mostly it's a private or a single family. The disease affects many organs, as we can see here. It affects the brain, it affects the eyes and the ears, the heart, joints. It affects also the kidneys, the CNS, and then the GI tract, as well as the skin. So it's a multi-systemic disease. The Fabry disease show a wide geographic variation. It shows high incidence in Italy by 1 in 37,000, and also in Taiwan 1 in 1,000 to 1,250 in males, and 1 in 40,000 females, as well as in Australia, and also later on come to Australia, the UK, and this in Netherlands. Of course, Fabry disease is considered to be a life-threatening disease condition that is often misdiagnosed, and the actual incidence is really what we believe is underestimated, especially here in our area. Fabry has difficulty in diagnosis, and the true incidence is really unknown because of the carrier states, and that, as we mentioned, that the prevalence in males is 1 in 20, while in female, while in the incidence is in 1 in 40,000 in males. And it is X-linked, so females to believe that they carry the disease, but sometimes they don't show any symptoms, or they show a very late symptoms that may be misdiagnosed. So what's the pathology behind the Fabry disease? We mentioned that there's a deficiency of the enzyme called alpha-galactosidase enzyme, which is present in the lysosomes, and this it is responsible for degrading a substance called the globotriaoscyl ceramide, or we abbreviate it as a GB3. This the globotriaoscyl ceramide consists of disaccharides, a chain of disaccharides with a ceramide. And this enzyme is responsible to degrade the substance by breaking down one of the saccharides molecules. And the deficiency of this enzyme will lead to accumulation of the GB3. And therefore, when this GB3 accumulate, it will precipitate in different organs. It will be in the endothelium, peripheral tissues, and the smooth muscle of the blood vessels. This is the pathophysiology, where we have the mutation of the GLA gene, as we mentioned. The deficiency of the enzyme will lead to GB3 accumulation, as we can see here. This is the normal lysosomes, and this is a lysosome that is full of GB3, showing vacuolated, what you call a vacuolated appearance of the cell because of the distension of the lysosomes, and these lysosomes got bigger, and this is the look of the lysosomes inside the cell. And this is a diagram explaining how the substance accumulate. This is the normal, where the GB3, the enzyme alpha-galactosidase is responsible to degrade the GB3, and this is the lysosome that is full of GB3 has not been breakdown, and this is the precipitation in the kidney, because as we mentioned, it will precipitate GB3, the accumulated, it will precipitate in different organs, and this is an example where it precipitates in the glomeruli of the kidney, and all this, the precipitation will lead to cell damage, and it will lead to cell death. So as we mentioned, it's not only in the kidney, but it's also in different organs, in the heart, in the nervous system, in the blood vessels, as well as the skin, and it causes cause damage to the cell function, and subsequently it will cause damage to the organs. And of course, this is a primary effect. A secondary effect, that this accumulated substance, this accumulated substance, it will cause an inflammatory and an oxidative process that also will lead to abnormal cell count alteration, and also cellular apoptosis and necrosis, and causes a necrosis of these organs. And of course, the variety of symptoms varies and depends on the severity of the disease. The inheritance of the Fabry is it's an X-linked disease, so it can be transmitted by both male and female. The female can develop the manifestation because either it's inherited or because of de novo or random de novo, and the affecting female is by what's called the X inactivation or the lionization. So if it's inherited, then if there is the activity, usually we deactivate one of the two X. So if the X has the normal X has been deactivated, and the disease X has been is the one that become more prominent, then it will lead to manifestation of the disease. And the same occurs when if this is a de novo, and then if the inactivation of the non-mutant X, or it will lead to prominency of the mutated gene in the active X, and lead to manifestation of the disease. The disease has two different phenotypes. We have the classic, or what we call the severe phenotype, and we have the mild variant phenotype. The classic is where we have a severe deficiency of the enzyme alpha-galactosidase enzyme, and the symptoms affecting many organs. And we have the common mutation is usually it's by either a large and small gene rearrangement, splicing defect, or it's kind of missense or nonsense mutation. While the mild variant, it causes a later onset disease, and there is a remnant of the enzyme, more remnant of the enzyme than the classic. And the symptoms generally restricted to the cardiac anomalies, and the mutation are typically of splicing defect or missense mutation. But however, there's a small number of the mutation that has been found that they have both can present as either classic or can present as a mild variant. And these are an example of three mutations here: the arginine 112 histidine, and arginine 31, and this again the glycine 328 arginine. And these kind of mutation, they can either present with the classic or can present with the mild variant of the disease. So what organs, and we will go for some details about what Fabry disease can cause. As we mentioned before, it involves many organs. It causes generalized fatigability and decrease in the activity. And in the eye, it causes the precipitation in the cornea called cornea verticillata. It causes also a hearing problem and hearing loss at tinnitus. In the CNS, it causes either early strokes or transient ischemic attack. It causes also peripheral neuropathy and burning sensation with a severe pain, and sometimes they can come with a pain crisis, or them to be misdiagnosed as rheumatoid arthritis or other peripheral neuropathies. And it can come also as psychological issues like a depression. Other also organs involved is the skin, where there's a hypohidrosis or angiokeratomas, and these are how the angiokeratomas look like. And of course, they will have a dry skin, they have exercise intolerance, and always feeling cold. Other major organ involvement is the cardiac, and the renal. And the cardiac, they will have arrhythmias, they will have conduction abnormalities, left ventricular hypertrophy, and they will have and with change in the ECG, they will have also a valvular dysfunction with a myocardial infarction, heart failure, and may lead to a sudden death. In the renal, they they will have a decline, a gradual decline in their glomerular filtration rate and or albuminuria, proteinuria, and it may lead to an end-stage renal disease. Another system effect is the GI, because this substances also will accumulate in the intestinal wall, causing cramps, recurrent diarrhea, bloating, and nausea. So we can find that how big is or how diverse is the symptoms that this patient will come with it, involving many organs. So the symptoms, the early symptoms that usually we see in pediatricians most likely is the pain, some GI symptoms, the recurrent diarrhea, the hypohidrosis, cold intolerance, recurrent febrile illness, and impairment of quality of life. While during the adolescent and the adult life, there will be more of a renal failure, the cardiovascular complication, and the CNS complication and early death. And this occurs, mostly rise up between the third and the fourth decade of life. In female, as we said, that it is X-linked. So does female have symptoms? Yes, female, as we mentioned before, females patient can be affected and can be just as severely as male, and with multiple organ involvement. And majority of the signs and symptoms occur after the at the age of 30. And the pain is, as we can see here, that the pain is the most prevalent symptoms of the disease in a female, and occur in about 65% of the females. Fabry disease, as we mentioned, it's a progressive life-threatening disease. It is misdiagnosed and it's underdiagnosed, and we can see that it decreases the life expectancy in males about by 16.5 years, and in female about 4.6 years. And the main age of death has been reported in female in males with the disease is about 51.8, and in the female is 64. Of course, the quality of life in the comparison, we can see how it affects the quality of life, and pain is considered to be, in both male and female, is considered the most debilitating symptoms that they will. Another one is the depression also that will affect their quality of life. Last year we did a meeting between the expert in Fabry disease and recommending how to diagnose for the patient in case in Saudi Arabia, and discussing how to diagnose these patients and the best method to diagnose these patients, and also discussing about the management and the when to start the treatment, and also the monitoring of the disease. And we will also, during this talk, I will summarize what we have reached during our meeting. So in the diagnosis of Fabry disease in males, the committee or consensus agreed that in the males, that testing for the alpha-galactosidase enzyme or the Fabry disease usually occur in DPS, which is the filter paper, or they call it filter paper. The first step is by indicating the testing of the enzyme and the biomarker of the disease, which is the lysosomal GL3, and if it's negative, that for males it indicates that this is a normal enzyme activity. But if it is positive, there is either a low or borderline enzyme, then we look at the lysosomal G3 as well, and if it's high, then we possibly give the possibility this is really Fabry disease, and we confirm the diagnosis by going to the molecular testing and finalizing our diagnosis. In female, it differs. So we use both the lysosomal, the enzyme assay, as well as the GL3. So if if it's normal, the enzyme activity, we look also at the GL3. If it's normal, this is most likely not a disease. But if there's the enzyme is borderline, low normal or low, with an elevated GL3, then we give the high suspicion this is a Fabry disease, and we proceed for the genetic test. And of course, we considering that the enzyme activity and the GL3 can be of a normal range in affected female, and therefore, if the clinical suspicion is still there by family history or by the symptoms, then even if it's negative, then we go also for molecular testing. So the current method that used for the diagnosis of and assessing of patient with a Fabry disease, so it depends on the family history. If you have a positive family history or we have a symptoms that suggest of Fabry disease, then we go for the enzyme assay as well as the biochemical test for the biomarker, the GB, either the GB3 plasma or urine GB3 or the lysosomal GB3, and we go for the enzyme activity for both of these. If the initial test is positive, and then we go for the genetic test to confirm, and we do all these baseline. These are the baseline investigation that we do for patients who are suspected to have a Fabry disease, and including the quality of life assessment scale, neurological investigation like the brain MRI, EEG, hearing, the eye and ear by slit lamp examination, audiogram, renal function, the urine dipstick for protein, 24-hour protein, and biopsy if indicated, and also ultrasound for the vasculature. We also assess the cardiac by doing the ECG, the echo, 24-hour monitoring, and assessment of cardiac function. In the GI, we depend mainly on the symptoms by the diarrhea, the constipation or abdominal pain, and also the dermatology, we depend mainly on symptoms of angiokeratomas and dehydrosis or telangiectasias. And of course, as we can mention that so many specialties are involved, so patients can be diagnosed by early strokes by neurology, can be diagnosed by a cardiologist by the left ventricular failure, left ventricular hypertrophy, or can be diagnosed by nephrologist through the gradual decline in the renal function. Just mentioning that elevation of GP3 in the urine plasma has been used usually as a diagnostic, but it's not. But it is really a poor indicator of any progression. So we use more. Better to use also lysosomal GB3 and correlate with the severity or detect an early stage rather than the plasma or the urine GP3. So the therapy that is for treatment for Fabry disease, we have an existing therapy that already approved, which is enzyme replacement therapy, and we have two ERTs are there: the alpha galsidase alpha and galsidase beta, as well as there is a newly drug pinguigalase, which is a plant derived that has been approved in 2023, May 2023. We have currently also the chaperone therapy, which is megalostate, and we have a therapy that is emerging in the future, which is the plant derived, which is already has been approved, and the substrate reduction therapy as well as gene therapy that we are looking at as a future treatment. The enzyme therapy, which one to start, of course, as the consensus decision that for the in Saudi Arabia that we also looked at the international recommendation for the initiation of therapy, and we came with the recommendation that the man, whether he is symptomatic or asymptomatic, he should should be administered, and of course the older he is, the more morbidity and the less the more complication, and of course the enzyme will have also some more limited effect. For the women, if they are symptomatic, showing any neuropathic pain or proteinuria or transient ischemic attack or stroke, or they have cardiac symptoms like dyspnea or have GI symptoms, then they are candidate to go for the enzyme. And those women who are asymptomatic, so we should consider follow up, and if they show any renal impairment or any cerebral matter or any cardiac complications, and then they are candidate actually to go for the enzyme therapy. The late onset Fabry disease for men and women, the ERT is considered recommended according to the manifestation that we mentioned, and then the ERT should not be used to treat patients who have the benign GLA polymorphism that will characterize an ERT should not require and be required in the absence of any tissue pathology or clinical symptoms associated with Fabry disease, especially for the heterozygous female. And also there is a recommendation for a multidisciplinary care for these patients. The second available medication is the chaperone, which is the miglustat therapy. It is suitable for certain mutation. So it's mutation related. For misfolding is the one candidate for this miglustat. Otherwise, if it's not the if not the mutation, then it is the mutation that is responding for the miglustat. Then we go for the enzyme therapy. Another therapy is that coming in the future, the substrate reduction therapy, either the venglustat or the lirostat, and these are they reduce the synthesis of the GL3, and they are under clinical trials now, and they show promising biochemical efficacy and tolerability. The advantage of these medications is that they are very effective in the management of Fabry disease and reduce the lysosomal GP3, and they improve the outcome of these patients in the Fabry. However, they have some side effect in some patients, and also the long-term effect of these is still not yet studied. The gene therapy, we have, of course, either we use the virus vector. We use lentivirus that implemented in the bone marrow in the hematopoietic stem cells, or we use the adeno-associated virus that is introduced in the liver or the muscle. And we use another one is the use of nanoparticle encapsulated mRNA, and the CRISPR-Cas9 is also a promising treatment, but is still facing some challenges. The advantage of that is these are a long-term therapy, so it offers a sustained therapeutic benefit through a long period of time. It provides a more target and efficient approach to address the disease, and it also reduce the side effect of the treatment, and it improves the quality of life by improving the quality of life. And also it does not have the disadvantage from the enzyme replacement with the developing of antibody against the enzyme. However, we have some challenges, like we face a challenge that of the efficiency of delivering the gene through these viruses or this technology, and it may trigger some immune response to the virus, and of course it will decrease the success of the treatment, and of course we may experience a long-term struggling to achieve the long-term gene success. So this treatment can be again repeated. And of course, the high cost of this treatment, if you have, for example, a good number of patients, then the cost of this treatment is still very, very high comparing to the other treatments. Of course, these patients, they need also not only the geneticists, and they need also other subspecialty to take care of them. They need a multidisciplinary team to take care of the patient with Fabry. So we have, in addition to the ERT, we need the neurologist to manage their pain and their strokes, and we need the nephrologist to manage their complication, the renal complication, the ENT to manage their hearing loss, and by giving a hearing aid or cochlear implant, and also the management of their cardiovascular system by the cardiologist, and the GI, of course, can be involved for their GI symptoms. Also, we need a good psychological and social support for these patients. Of course, monitoring these patients on our meeting, and we agreed that we have some certain criteria to monitor in these Fabry patients, and these criteria actually it goes also together with the international guidelines. And so these patients, when we want to monitor them, whether they are a patient without treatment or a patient on treatment, then we have to look at the clinical assessment. So every time they come, we ask the question related to different manifestation of the disease to see whether they started to have symptoms related to the other diseases. So we need to do the plasma, the plasma lysosomal GB3. We need to check their renal involvement, heart involvement, neurological involvement. Also, we need to assess the quality of life, and really the expert opinion during this meeting matches exactly what's there in the international guidelines. So on monitoring, we should agreed on that a follow-up should be at 6-month interval for patients who are receiving ERT, and those who are not on ERT every 12 months. And of course, this also can be individualized depending on the patient. So what we do at each infusion, we assess their vital signs. We assess any adverse event that happened during the last infusion, and we try to modify their medication or their treatment according to what for those who need a follow-up. And every 6 months, we take medical history, we do a clinical examination, we do pain scoring, a quality of life assessment, we assess the disease, we make a disease severity assessment, and we do the blood test as well as the ECG. And for those who are on 12-month follow-up, especially those who are not a treatment, we do, in addition to what has been done for those on 6 months, we do also assessment of the GFR, with 24-hour urine protein, cardiac assessment, including MRI and audiology, as well as for those who are on enzyme, we do the antibody testing on annual basis, and we test plasma and urinary GP3 for those who are on treatment or not on treatment. And this is of course the list what we do, exactly what has been told in the last slide. So then we also recommend that on monitoring, we do the severity score assessment and follow-up. We have two kinds of severity score assessment, which is the Men's Severity Score Index, the MCCI, and the Severity Score System, D3. They provide a snapshot patient clinical status, but are less effective in tracking what changes happen over the time in this patient. So both scores, they evaluate different aspects of the disease, with, of course, the MSSI focusing on general neurological, cardiovascular, renal manifestation, while the DS3 including the patient-reported domain. These are, of course, the differences between them, and we can summarize it by this table that the MSS has 4 domains, 24 items, while DSE has only 5 domains with 12 items. Both they focus on this severe disease severity, but however they are and the dynamic assessment and they are very useful comparing the disease burden only, and the clinical stability. There's no direct assessment of this. So nowadays we use more what's called the FASTIX, the Fabry Stabilization Index, that developed it's almost since 2016, and it addresses all the limitation that is there in the MSSI and the DS3. And here is the score for the assessment of the FASTIX Fabry disease assessment tool, that it's used for both patients who are not on treatment and those patients who are on treatment, and on treatment to assess the stability or the progression of the disease. And of course, most the expert the opinion they use, of course, here in Saudi Arabia, actually, majority of the experts they didn't use, but we all agreed that for untreated as well as those who are on treatment, it's a good monitoring. It's the best monitoring for the disease progression and disease assessment is the FASTIX tool, and we use the after this score, as we can see here, it look at the nervous system, renal assessment, the cardiac assessment of the disease, and it gives a score for each one. Every time you do this scoring, you compare the score to the previous one, and if it is 20 or less, this is mean it's disease stabilization. If it is more than 20 or more, it indicates that there is a disease progression. For those who are not on treatment, then we recommend to consider the treatment, and those who are in treatment, we need to look at the treatment, whether we need to increase the dose or to change or to look at the patient compliance, or to look at what is the cause of the progression of their symptoms, and behave accordingly. So in summary, Fabry disease is an X-linked lysosomal storage disease. The timely diagnosis of disease, it involves many organs, causing the damage of several organs. The timely diagnosis and early initiation of the therapy is critical in Fabry disease, and it prevents irreversible damages. Current treatment is available, as well as there is a future treatment. The current treatment is the ERT as well as the chaperone, and for future treatment is we're looking at another substrate reduction and the gene therapy. Delayed diagnosis will give you an irreversible organ damage, and the early treatment will definitely improve the outcome of the disease and improve the quality of life of the survivors. And the most important cause of death in these patients is the cardiomyopathy as well as the renal diseases. And we recommend to do an early diagnosis and a good monitoring using the tools that has been mentioned in the monitoring of the disease. And of course, these are the just reminder for the audience of the different disease, different involvement of different organs. So if they have anything, a patient with multisystemic involvement from here and there, then they should consider the Fabry disease. And here also the Sanofi contacts that if they have any suspicion, they can contact the Sanofi for to facilitate the diagnosis, because they provide the enzyme assay, GP3, as well as the genetic tests for free. Thank you very much for listening and then for your attention. And please, if you have any question.
Thank you, Dr. Ravda, for your outstanding presentation. The question will be at the end of the webinar. So we'll move now to our next expert, Dr. Mamdouh Kalakatawi, who is the head of a neurology department at a neurospecialist hospital in Al University, and also associated professor at Al University. Dr. Mamdouh has plenty of publication and also teaching several student, fellow, and resident. And Dr. Mamdouh will enlighten us about Fabry disease management in practice, hands-on experience. So the floor for you, Dr. Mamdouh. Dr. Mamdouh, you are on mute. Dr. Mamdouh.
بسم الله الرحمن الرحيم. بسم الله والصلاة على رسول الله.
Presenting mode, please.
Yeah, you are hearing?
Yeah, we are hearing you, but the presentation not in the presenting mode. So if you can put it in the presenting mode. If you could.
It is in sharing now?
Yeah, we can see it, but it is not in the presenting mode. So if you could put F5 or the presenting mode,
I don't know. I mean, we can ask the people.
it's down in your right, I think, or
It's coming now.
yeah, now it's great. Please go ahead.
Yes. Okay. Again, thank you for Sanofi for this opportunity to share our experience in the Fabry case disease. We thank Dr. Majid for introduction. We thank Dr. Rauda for this excellent introduction. For this introduction. Today, I'm sharing with this this disclaimer by the lecture is sponsored by the Sanofi company. So our first case is Abdus Salam. He's 20 years old, Saudi Arabian male soldier. His problem start on August 2022 when came to our hospital complaining with the undefined burning pain referred from the Security Force Hospital for nerve conduction. As we are routine examine the patient from the neurological view, the patient have normal neurological examination, except we noticed that the patient appear anxious, depressed, with the hyperalgesia, with more pain on touch, with a little hair on his dry, shiny skin. The blood pressure on assessment was little bit high, 160 over 90, with a little bit fast atrial fibrillation. So we did for him the EMG nerve conduction study. Actually was normal, and we report for him as normal nerve conduction. But we comment that the still small fiber neuropathy or central cause to consider. For the patient was much smart to stop us at this point and to say that I'm suffering from pain since the age of 16 or maybe before. I cannot live normally, not study, not work, and not have a friend, not married, and not think even in marriage. Take a lot of medication that is useless. So we give him a chance to present his history in spite of the short time in the EMG clinic. He told since 2015 have a severe burning pain that start as recurrent mainly on the winter and then progressed to be more persistent on 2019. The patient at that time started to follow the neurology, different private clinic, and almost was refractory to a lot of the neuropathic medication, including pregabalin, carbamazepine, tramadol, duloxetine in high dose, and the recurrent painful migraine using the topiramate in high dose 100 milligram once daily. In addition to this neurological problem, he was a lot of complaints, a lot of follow-up since 2012. Followed the dermatology with the undefined hand and the feet, heat and the cold intolerance, and the dry skin was almost daily on certain creams. Since 2014, followed the cardiology with undefined palpitation, diagnosis and the atrial fibrillation with left ventricular hypertrophy and the mitral valve prolapse on the bisoprolol 5 milligram. Since 2017, followed the nephrology with the undefined hypertension and proteinuria on the valsartan. And since 2018, followed the psychiatry with an anxiety, depression on the escitalopram. We told him because we appreciate your request and we understand his complaint. We opened for him file in our hospital in spite is following the security force hospital. We told him could this be from drug addiction, could be psychogenic, could be central. We think about multiple sclerosis, but still small fiber neuropathy with rare disease like a Fabry. So we'll do a lot of investigation and we'll see that. So we request for him MRI, and we did visually focused and toxicology, and we check for the Fabry with the diagnostic blood test. We thank the company to provide it in the clinic. So after 1 week, we get the result. That is the patient is positive Fabry with low enzymes and the high GL. And we confirm later the genetic mutation. Other test was almost unremarkable. Just the chemistry showed the upper normal, the urea, and the creatinine, and the MRI show non-specific white matter signals with the ECG with left ventricular hypertrophy and also in the echo. So in 2022 November, we start the enzyme replacement therapy. Every 2 weeks. Initially, we started in our hospital, and then we left the patient for the home infusion care. And we continue the follow-up every 3 to 6 months with the multidisciplinary care and clinic referral to the psychiatry for phobia, depression, cardiology for the arrhythmia and the left ventricular hypertrophy, also for nephrology, dermatology, and ophthalmology, and the NT. On November, we start the family screening. As everybody know, every positive patient will have at least 5 patients around. So we start with the family screening, and actually the family screening is not easy because we have first to convince the patient to accept, to tell the other his disease, and to take their acceptance to be part of this study. Unfortunately, the father refused, and he's not complaining, but the mother and the sister refused initially, but then we able to confirm the Fabry disease with them. The mother most probably the source for Fabry disease in this family. The 2 brothers accept. The one of them, Abdul Ghani, is normal, but the other, Muhammad, was positive for Fabry disease. Unfortunately, and this is one of the difficulty with the family screening, that the Abdul Salam is not agree to check the other family, like the family from his mother or father, and only we are limited to study that in his close family. I mean, the brother and sister and the mother. The other patient, Muhammad, he's 21 year, student in university. We able after the confirmation of the Fabry disease to have interview for his history. Unfortunately, he have a very big history since the primary school, where he stigmatized as psychiatry boy from that age, with the claustrophobia, social phobia, anxiety, and depression. So was in bad scoring in the school because of that phobia, depression, with unexplained recurrent fever and poor sweat that need almost paracetamol frequently daily, with unexplained nausea, food early fullness, was not able to take any meal at the school, with the limb numbness and the heat intolerance, with the dry skin and the eyes. So even he cannot be part of any activity in the school, like sport or whatever, with the recurrent blood blocked ears, with rash on the genital and the buttock area. So again, as his brother was on the big list of the follow-up, so since 2014, followed the pediatric for fever for investigation. On the 2015, follow AT with the air block, air pain. 2015 also with ophthalmology with the eye dryness, usually on the eye drops. 2017 in the dermatology with the angiokeratoma on skin cream. 2020 with the psychiatry on the paroxetine. So again, when examining the patient has nothing on the neurology examination, except that the patient is look very depressed, look shy, not speak, not talk at all. We get any simple talk by big pressure, and general examination only the angiokeratoma, the rash. Again, his workup was unremarkable: EMG, nerve conduction, MRI, brain, cervical, and the echo, and the ECG was normal. So Muhammad started in March 2023 the enzyme replacement therapy. The same as his brother, started initially in our hospital and then at home, with the follow-up in the clinic, neurology clinic, and the other clinic, including the gastroenterology, nephrology, cardiology, psychiatry, and the ENT, dermatology, and ophthalmology for his complaints. So we'll see the patient after the enzyme replacement therapy. The first case, Abdus Salam, he almost now follow us in the clinic with about 2.5 years on the enzyme replacement therapy. Neuropathic pain, dryness, heat, cold intolerance, migraine, depression decrease gradually, and the frequency and the severity, and even the cardiac with the atrial fibrillation, hypertension, okay, control in the small dose. If you see the chart, we see that in our initial November 2020 have a big list of medication, but on our last follow-up on that the March 2025, almost take no medication for the neurology, and only in the cardiology, bisoprolol 2.5 milligram and the valsartan 40 milligram. So even the radiological MRI, echo, and ECG showed no change with improvement. The echo with the mild left ventricular hypertrophy with no worsening. Chemistry almost become normal. Urine analysis is still the proteinuria, and the neurological assessment and general assessment show the patient become more hopeful, more happy, more productive at work. He's a soldier. Even he was not able to wear the shoes, wear the cloth of the soldier and the military dress. But now he's working very nice, with no sick leave, dependent on himself, and currently he's engaged and soon to be married with thinking to build a family. Okay, the second case, Muhammad, in about 2 years, enzyme replacement therapy, the phobia, depression, the social isolation, skin dryness, and intolerance all gradually decrease, and frequently, the frequency and the severity. And the shy, crazy boy become very stable. He's speaking, he's discussing his problem and explaining his problem to others in a very nice way. And even the irritable bowel syndrome become stable now. If you compare it from March 2023 with a lot of medication, now he never take any medication. So again, in the investigation, MRI have no change, echo no change, ECG still normal, chemistry normal, and generally the patient become more confident, no phobia, no social isolation. He's doing very nice in the university, no escape from the lecture, and his score in the university become excellent. So this the two patients we present who started in the enzyme replacement therapy, but we present the other two cases. The mother, Naila, she started now he's age of the 45. Since the age of 35, in about 10 years, start to complain from the hypertension, left ventricular hypertrophy, bundle branch block, bradycardia, with the chronic migraine, the recurrent hemiplegic or TIA-like presentation, with the social phobia, paranoid delusion, with the poor clinic follow-up. She said, I'm afraid from the hospital, has nosocomial type of phobia. MRI non-specific with the white matter change. The EMG was normal, chemistry, just the urea in the upper normal, and the urine analysis showed the albuminuria. The Fabry just confirmed 6 months ago, and the hair enzyme replacement therapy ready, but still reluctant to start. Maybe she afraid from the hospitalization, but will try to confirm her, inshallah, more. The other, the fourth case is the sister, Shahad, is about 22 years, Saudi housewife, patient have since about 5 years, the bradycardia with the postural hypotension, severe anxiety causing marital problems, with the chronic migraine, need high dose Botox, and the total body numbness make even her life is miserable. Even the usual daily activity is limited because of this numbness and burning sensation. MRI, again, non-specific white matter change, MEG normal, chemistry and urine analysis still normal. Fabry disease, again, with the mother confirmed 6 months ago. Now she's pregnant on the 6th month. So we hope to start the enzyme replacement therapy after the delivery. If you see, this is family. We have a very different phenotypic presentation, but it seems that the male appear a little bit earlier, while the female appear later in the presentation. So this is my cases, and this is the Sanofi referral for any questions and report. And we thank the audience. We thank Dr. Majid, and maybe the question at the end as you know. Okay, thank you.
Thank you, Dr. Mamdouh, for this great presentation and this very interesting case presentation. Now we will move to our next speaker, Dr. Khalid Naji, Senior Consultant Cardiologist at Prince Sultan Military Medical City with advanced expertise in cardiac imaging. He holds MBBS from King Saud University and complete his internal medicine and adult cardiology training in Saudi Arabia, then do further fellowship training and certification in advanced cardiac imaging, including cardiac CT, MRI, PET, SPECT scan, and the nuclear imaging in general at Ottawa Heart Institute in Canada. Dr. Naji has plenty of publication, teach several students, president, and fellows, and he added a lot to scientific and academic community. So welcome with me, Dr. Khalid, who will present about navigating complex monitoring scenario, real-life Fabry disease. All is yours, Dr. Khalid.
يعطيك العافية دكتور ماجد. Thank you for your nice introduction, and thank you Sanofi for sponsoring this event. And by the way, I'm still not senior consultant, I'm young. لكن إن شاء الله I hope with years إن شاء الله will be senior in my service to my patients. So today inshallah we will talk about Andersen-Fabry disease from cardiology perspective, and I will try to shed some light on rare disease, because the Andersen-Fabry disease for sure is there in our community, but we need to increase the awareness and how to suspect Fabry's in our population. So I will start with this slide, and my idea here is merely that remember that Fabry's is X-linked. Why this is important? Because the diagnosis of Fabry's in any patient will help in two things. First thing, just remember, since the Fabry's is X-linked, so you can help the patient himself and his family. And second thing, that is not only manifestation, it's not only clinical manifestation, because clinical manifestation of Fabry's is not really easy to suspect. That's why you need most of the time to involve genetic tests to confirm the diagnosis. And as Dr. Rauda said, we have different phenotypes for Fabry's disease. We have the classic type, when we have really deficiency in the alpha-galactosidase activity. So the patient will present earlier in life, in childhood. They can presented with multi-organ involvement. And we have the non-classic phenotype when the patient present later in life with cardiac involvement presentation mainly. And we have the female, since they have a heterozygous mutation, they behave or they present slightly different from males when they have more indolent presentation, more vague symptoms, and different organ involvement. So I will start here with this patient. It's a real case from my clinic. He is a 51 male patient who's labeled as multiple sclerosis. He had history of paroxysmal atrial fibrillation and hypertrophic cardiomyopathy. He was referred to my clinic as a case of hypertrophy. So just to investigate more and optimize his medications. So what we did for him for sure the basic cardiology screening like the ECG, MRI, and echo. As you can see in the echo, there is like diffuse concentric thickening of the myocardium, and we did the MRI. This is all the MRI, so this is the best, quality I can provide. But you can see there is like some mid-wall fibrosis in the basal infralateral, which is more like typically described in Fabry's patients with diffuse concentric thickening of the myocardium. In the ECG here, you can see some clues for Fabry's in general. So apart from the LVH criteria, you can see there is short PR with some delta wave indicating pre-excitation finding on the ECG. So when I saw this patient, in the same time, I was in contact with Sanofi, and they offered the idea of genetic testing for cardiomyopathy patients. So what I did, we sent for this patient, and it came back positive. The patient has high lysoGL3. In the same time, he has the mutation of Fabry's. So actually, what this patient have is Fabry's disease, and maybe I'm still waiting the feedback from my neurology colleague to confirm that maybe his multiple sclerosis is actually Fabry's, and it will explain the whole presentation. Also, during the patient follow-up in my clinic, the patient developed a stroke. So combining all this presentation, maybe I can blame one disease, which is the Fabry's. When we did family screening, so the patient has 4 siblings, and both his doses, they are carrier as expected for Fabry's disease. My second patient actually is interesting. She is a 21-year-old female, medically free. She presented with atypical chest pain, dizziness, and palpitation. And the first time I encountered this patient, I was actually doing her cardiac MRI report. So what's interesting in her case that the reason for cardiac MRI was recurrent pericarditis perimyocarditis in the last 2 years. So as like apart from my interest, I asked my colleague to refer this patient to my cardiomyopathy clinic. So I did for her the basic workup, including for sure the MRI as we described. We can see this basal lateral epicardial fibrosis. Nothing much to say in the ECG, and nothing also much to say in the echo. So initially, to be honest, I thought that maybe what my patient have is arrhythmogenic cardiomyopathy, explaining her palpitation, chest pain, and all of that. And to be honest, by mistake, it was sent a genetic test for her. And the genetic test came back positive for Fabry's. So I thought maybe there is like a mislabeled sampling, and this is no way it can explain. So what we did, we sent again another genetic test for the patient. It came back positive for the same mutation, and when we did family screening, we discovered that all the patient's sisters, she has like 3 sisters, all of them, they are carrying the same mutation, and her father also is a carrier for the mutation. A third case, but not from my clinic, from the literature, is about a patient who is in 50s. He was he was found to have a systolic murmur in his examination, LVH in his ECG. The echo showed diffuse thickening or concentric thickening of the myocardium with some AVOT obstruction. So for any cardiologist, he will say, this is simple, straightforward case. This is like HOCM case. What the patient did is, as expected, he was sent for surgery and they did for him a myectomy. So simple, like HOCM case that we see in daily practice. This is his ECG. You can see this LVH. There is like maybe some short PR. His MRI was not typically like, it's not typical Fabry's cases. You can see this mid-wall patchy LGE in the areas of the maximum thickness. So the patient was following in the clinic, and decision was made to involve this patient in a genetic study for cardiomyopathy. And surprisingly, the patient's genetic test came positive for Fabry's. So the idea here from this case report that sometimes some typical, let's say, cases of cardiomyopathy, you will surprise that it is not only just simple hypertrophic cardiomyopathy. Maybe the patient have a Fabry's and they can present, in this case, for example, with HOCM. And when they did family screening, the patient himself, like his daughter and his granddaughter, all of them, they are carrying of this mutation. So remember that if you diagnose patient with Fabry's, you can help him and help his family. So the classic Anderson-Fabry disease is characterized by an array of symptoms in the childhood, including neuropathic pain, skin manifestations, GI symptoms, and maybe kidney involvement. And once there is early stroke in the third or fourth decade of life, and once you have a cardiac involvement, it's carrying a poor prognosis, and this may be the leading cause of death in Fabry's disease. And remember that the Fabry disease, they can present with diffuse concentric hypertrophy, but sometimes in females, they can have this borderline hypertrophy, and they don't present like male in terms of aggressiveness and clear presentation. So what we want to see in the ECG, we want to see maybe a short PR, the LVH findings, the delta wave and pre-excitation in the ECG. They can have sometimes arrhythmias like atrial fibrillation, flutter, and some conduction disease with the ongoing or continuous deposition of Fabry's deposits. In the echo, you can see diffuse concentric LVH, mainly involving the papillary muscles. And when you apply the strain analysis, you can see abnormal strain. Typically, it should be in the basal infralateral, but sometimes, depending on the area of deposition, you can see the abnormal strain. The MRI is quite helpful diagnostic imaging diagnostic modality. So, for example, here in the number one, this is normal patient. There is no hypertrophy. There is no abnormal T1 mapping, and there is no, area of fibrosis. The next patients here, this is a young patient with early manifestation of Fabry's when they have abnormal T1 mapping. The area here is the area with low, I will not go like deep in the MRI sequences, but this is abnormal T1 mapping. When we have low T1, that means there is a lipid deposition in the myocardium, but there is no area of fibrosis. And here another two examples of elderly patients, male and female patients, when they present later and they have both abnormal T1 and evidence of fibrosis in the MRI. The MRI also can help us to differentiate Fabry's from other cardiomyopathies, but remember the MRI is not histopathological diagnosis, but we have different patterns in the T1 mapping and fibrosis pattern. And this can help us to suspect and to maybe sometimes differentiate between Fabry's and other cardiomyopathy. And also the MRI can help us to know exactly where is our patient. Is he early in the disease, in the accumulation phase? Is he in the inflammation phase? Or it's too late when we have diffuse fibrosis. And again, we are using the T1 mapping and the late gadolinium enhancement to describe any fibrotic area. I always tells my fellows that we have the hypertrophy mimics. So, for example, you can see in the ECG, for example, for Fabry's disease, we have the short PR. We can have a low global longitudinal strain, particularly in the infralateral and right ventricle. And you can see area of fibrosis or late gadolinium enhancement in the basal infralateral wall with a low T1 in the MRI, but sometimes with the continuous like deposition of this lipid deposition in the myocardium. In the same time, if we have a fibrosis, sometimes we can have a pseudo normalization of T1 because we have both like fibrosis and lipid deposition. In comparison to other hypertrophic cardiomyopathy, we can have, for example, low voltage creatinine in the ECG. In the same time, we have LVH. So there is concordant findings of low voltage and hypertrophy in echo. And we can have some abnormal strain pattern in the echo, for example, Sharon top for the cardiac amyloidosis. And typically in the MRI, we have very high values of T1 and ECV. For the hypertrophy also, for sarcomeric hypertrophic cardiomyopathy, we can have this sometimes diffuse or focal hypertrophy. We can have the LG that seen typically in the patients with hypertrophy. And hypertensive disease, usually there is no specific patterns. We can see for sure the LVH in the ECG. We can have concentric pattern of LVH in the echo, and rarely the LVH will exceed 15 millimeters, not like hypertrophic cardiomyopathy in general or Fabry's in specific. For me as cardiologist, I don't encounter patients with, for example, neuropathic pain, GI symptoms, or skin manifestation. But if someone asks me, this patient is in his third or fourth decade of life and he has cardiomyopathy, or he has renal disease, or he has like a stroke, this is unusual for a patient in his third or fourth decade. So always put Fabry's in your differential diagnosis as in your working list. And for me, I for sure like remember all these red flags for the cardiac manifestation of Fabry's. For the extra cardiac, it's not easy for me to dig in the more in the history, in the neurological history or nephrology history. But I like to ask just some simple questions. Do you have like neuropathic pain? Do you have GI symptoms? Do you have any skin manifestation? Do you have any family history? And this, I will use this history to support my suspicion and my workup. So remember that the Fabry's is not affecting the cardiac or kidney or skin. It's like multi-organ involvement. And I will emphasize that try to build your multidisciplinary team. Like in my practice, in a military hospital in Riyadh, we have a multidisciplinary team involving cardiology, myself, my colleagues in the nephrology, neurology, and in the genetic department. And for the last 2 years, we are keep sharing cases between clinics. Like myself, I refer like almost two cases apart from the family members that we discover them in the screening. And my colleagues, they are referring also their cases to my clinic. So, and this will help to early diagnose patients, to optimize their treatment from multidisciplinary and specialties. And thank you. And I'm ready for any questions.
Thank you, Dr. Khalid, for this great presentation. Now the floor is open for question. So maybe until the question is ready, I will ask Dr. Rawda. Dr. Rawda, if you could give us like two, lines about the prevention of Fabry disease.
Prevention starts with the family screening, I guess, because once you diagnose one patient, screen the others, and of course we can for those who still in the age that reproduction age, they can go, for example, for the IVF to prevent the disease from the next generation. This is one. Or another form of prevention is the early detection is a prevention of this disease complications. So family screening is very important part of the of prevention of the devastating complications by early starting the treatment. Or as I mentioned, that family screening so that we can provide them, for example, if they are with the IVF for their future offspring, future offspring.
Okay, excellent. There is an announcement here. The CME hours, they will post, the organizing company, they will post the QR code. You can scan QR code and put your email, and then you will have the CME hour for this activity. I cannot see any question in the Q&A box.
Dr. Majid, if you allow me for a question for Dr. Rawda.
Yes.
Dr. Rawda, like when I'm reading about the Fabries and how should we screen, usually in what I read in the articles, like in female patients, we like to start for any suspected case to do a genetic testing. But in your presentation, you prefer to go and check the the GL3 level first, and if there is a abnormal level to go with the genetic testing. So do you think both approach is right, or what do you think?
No, I mentioned two ways. This is a way that you go for example, for the enzyme. If the enzyme normal and, for example, but the lysosomal GB3 is elevated, then this is, I give you a suspicion of the disease. So you go for genetic test. If you have symptoms, or for example, you have family history and you still have suspicion of this patient that is still, then even if the GB3 is normal or the enzyme is normal, go for genetic test. These are the two scenarios that I mentioned in my lecture. Because you cannot depend on the enzyme in a female patient, or you cannot depend on the GB3 also in a female patient who is a carrier, who is maybe asymptomatic, currently asymptomatic, but still she's having the mutation of the disease.
Good.
Okay, there is here one question about from Dr. Al-Tayyib. Thanks for interesting topic. Could you please tell us what about prognosis of Fabry disease? Maybe Dr. Mamdouh, if you could answer this question.
Yeah, thank you. The prognosis of Fabry disease, it is really the variable, depend on the phenotype, depend on the the onset of disease and the early diagnosis and the ability to start any treatment, either the supportive therapy for cardiac and renal and main therapy like enzyme replacement therapy. So if a patient, unfortunately, like a male, present early, usually the complication will be more and the prognosis will be bad if you not get the chance of supportive therapy and the main therapy. Patient start late disease with mild phenotype usually maybe survive normally with little complication. So you have good prognosis, especially if you start the main therapy like enzyme therapy, whatever available. Yes.
Yes, thank you, Dr. Mamdouh. The other question it looks for Dr. Rawda. Are there emerging epigenetic or modifier gene interaction that contribute to disease severity beyond lionization in female?
Yes, always there. There is a gene modifier in all diseases, not only Fabry. We have in all diseases, whether this is a dominant or X-linked or autosomal recessive, we have a variety of presentation of the disease in the same family, in the same, and this is because of the gene modifier, the interaction, which we believe are gene modifiers, and they contribute really to the severity. In addition, of course, as he mentioned, to the lionization. There is also the theory of gene modifiers is there, not only in the X-linked, but in all diseases.
Excellent. There is other question. Any role of biopsy in the diagnosis of this disease? Maybe Dr. Khalid?
So I think for sure there is a role for a biopsy, but since we have like a lab testing for the GB3 for the lysozyme activity for the enzyme activity and the genetic testing, most of our cases we can diagnose them without the need for biopsy or for an invasive procedure. But sometimes if you are in doubt, you have contradicting findings, or for example, if you have a genetic testing showed, for example, a VOS variant of unknown significance, then the biopsy can help you. Or for example, if you don't have the access for genetic testing and you want to confirm the diagnosis, you can do a biopsy. If you have something obvious like in the skin or in the peripheral nerve involvement, you can do the biopsy. For sure, we will preserve myself the biopsy from the heart unless it is the last organ that or the only organ involved. I'll do a biopsy from the heart, but most of the time we don't need biopsy.
Yeah, sometimes we need biopsy to exclude the other possibility, but it can present the same like amyloidosis. Unfortunately, amyloidosis can present the same like a Fabry disease with the cardiac disease, renal disease, and the painful neuropathy, especially the small fiber. So here the amyloidosis, we can either check in the nerve or check in fact for the position for the amyloid. Unfortunately, very rarely, maybe two pathology will be present the same. So the patient will have a Fabry amyloidosis, and this will be very bad. But as Dr. Khalid said, now with the more simple the blood test, it has become easy to exclude Fabry, but very rarely to go to the biopsy, even whatever the nerve or brain or whatever else.
I have additional question just on this part also. If the patient is already in the stage renal disease, would this biopsy will help us to differentiate, or it will be these changes when the patient reached the end stage, it will not be specific? For renal, I mean, yeah.
I'm not the expert one to answer on nephrology, but I think the biopsy from the kidneys will confirm the diagnosis, but maybe it's too late to start a therapy to save the kidneys. But I think if the patient has end-stage disease, the biopsy will help to confirm the diagnosis, and it will not damage the kidneys. The patient already in this stage in disease.
Yes.
Thank you. The other question, how do you differentiate Fabry-related white matter hyperintensity from multiple sclerosis or other small vessel diseases using advanced imaging, DTI, or perfusion MRI?
Yes, I mean, this is one of the big dilemma when a patient confuses with the multiple sclerosis, as the case present to Dr. Khalid. Here, either we go to the same MRI. There is a specific sign called the venous sign, which is usually it is like a black dots inside the white hyperintensity. This is typical for multiple sclerosis, which is almost never present with the patient with Fabry disease. Usually, when we are in doubt, we'll go to do CSF with oligoclonal band, and this is usually not appear in the patient with the Fabry disease, not like the MS. So when in doubt, we have to do the CSF oligoclonal band.
Thank you, Dr. Mamdouh. The other question, I think, for Dr. Khalid, what specific cardiac monitoring guidelines should be followed for both male and female patients with Fabry disease?
So in the guidelines, usually for follow-up and treatment of Fabry's, there is you should remember that there is no like good evidence to support us regarding, for example, the treatment. But usually, what's recommended regarding the follow-up, we want to see the patient. So initially, when you see the patient for first time, you will do the basic workup, including the, as Dr. Roda mentioned in her slides, the ECG, the Holter, the echo, and if you have like cardiac MRI, you can do also for example, the cardiac MRI. And usually the recommendation, if there is no significant fibrosis in the myocardium, that means it is still early for the patient, and most likely he will benefit from the treatment.
Dr. Khalid,
To
yeah, your voice come back now.
yeah, the
Dr. Khalid, we cannot hear you now. Okay.
معلش أنا انقطعت يا دكتور.
Now you come back. It's fine. Please continue.
كان ما ادري ايش لكم اخر شيء كنت اقول يعني there is no good evidence about the medical therapy, but we like to manage them like any other cardiomyopathies with the beta blockers, ASRs, ARNI, SGLT2 inhibitor, and MRA, and just focus on few things like the patient is maybe at a higher risk for arrhythmias like flutter, so better to cover them with the anticoagulation. They are at high risk for conduction disease, so be careful if they describe some dizziness or they have findings on Holter that maybe need a device intervention.
Dr. Khalid, Dr. Rawda, what is the prevalence of Fabry disease in our region?
As we mentioned, that we don't know what's the prevalence of Fabry disease in our region, but we are sure that it is underdiagnosed. Actually, from literature, that out of one patient you diagnose a Fabry patient, then you have between 4 to 16 patients from that family that are affected with the disease. And we are facing, of course, the problem of disease stigma, and the patient, some of these families, they refuse the screening, which also make us not really diagnosing or knowing the exact number of the Fabry disease in the family.
Yeah, my question is there any power for authority to be involved in this screening? Because as you said, the best way of preventing disease or preventing the complication of disease, the early screening and early diagnosis. We face this one with our patient, but I don't know, is there any way for the Ministry of Health, the same as with the infectious disease, to be involved in this screening? Because as you said, if there is one patient, there is at least about 5 or 15 patients around. I don't know if there is any rule for authority, especially Ministry of Health, this is the metabolic disease and the other. I don't know what is.
No, unfortunately, we didn't have. It's all personalized. So if this patient is willing to take the test, it's okay. If he doesn't, then we can do any kind of force to let him come for diagnosis or for screening. Let's be clear. Even those who are sometimes screen and they know themselves that they have the disease, or for example, female, she has the mutation. Sometimes they disappear. They just disappear. They don't want to hear anything more. So we have a lot of challenges in this regard, and I think yes, maybe it should be like a rule. For example, in France, I think they have such a rule that it's mandatory that for a devastating disease like this to screen the family, and in certain diseases, of course. I think maybe Fabry is one of them. I'm not sure, but for example, in cancer, yes, I know that in certain countries that it's mandatory. If it's inherited, then it's mandatory whether these people they agree or not. It's mandatory. But here in our country, no, it's still not obligatory, and it's just depend on the person whether he is willing to go for it or not.
Okay, I think with
I
that,
think there is some diseases also has been put recently in premarital testing, but I think Fabry is not one of them.
I just want to add one comment. If we, in future, inshallah, if we can have some registry, so this will help us to know, if our country is prevalent with the Fabry's, what common genetic mutations we have, and the areas where the Fabry's is prevalent. I think this will help us to understand the Fabry's in Saudi and also in the Gulf area.
I agree totally with this comment. At the end, thank you for all the experts. You light our night with your huge experience and knowledge, and Dr. Rawda give us the guidelines and management, and then Dr. Mamdouh give us real case scenario with their management and response to treatment. And finally, Dr. Khalid give us the perspective of cardiologist and also real case scenario. Thank you for the audience to stay late today, and thank you for the sponsor and organizing company. And with that, thank you for all and have a good night.
Thank you.
Thank you, Dr. Majid, and thanks for Sanufi and for all the attendees and the speakers as well.
Thank you.